Welcome to Dispenses Written, and I'm glad you're here. This is part of a short mini-series dedicated to teaching evidence-based medicine principles. In this video, we're going to cover steps, 5 questions between you and a sales pitch. This is based on the framework of Dr. Mark E. Bell at AFP, titled Steps Drug Review. So, a new drug hits the market. The commercial is beautiful. The brand name was clearly chosen by a committee that spent weeks on it. And the rep who just left your waiting room had a smile that said, "I genuinely believe in this product," and a lunch that said the same thing.
A big old smile.
The question isn't, is it new? Everything is new once. The question is it actually better? Better for who and in what ways? And what cost? That's STEPS, a 5-domain framework from the American Family Physician that gives you structured lens for evaluating any new therapeutic option against what you're already doing. STEPS stands for safety, tolerability, effectiveness, price, and simplicity. 5 questions between you and a very convincing sales pitch. So why do STEPS analyses matter? New doesn't necessarily mean better. This should be embroidered on every white coat in medicine. But novelty is well marketed, and without a framework, it's easy to mistake it for progress. STEPS doesn't tell you what to prescribe. It tells you what to ask before you do. And it forces you to ask all 5 questions, not just the ones that happen to show up on a slide in the conference room, because a drug can spectacularly be effective and completely impractical. It can be cheap and intolerable. It can have a clean safety profile and a dosing schedule that guarantees non-adherence. Any single category in isolation can mislead you. All 5 together give you the complete picture. So let's break each of these 5 domains down. The S for safety is, what are the known risks? What are the black box warnings? Are there any post-marketing signals that didn't show up in the trials? And critically, what are the known unknowns, the things that we don't have long-term data on yet? T is tolerability. Will patients actually stay on this? What is the side effect burden? How quickly can things get uncomfortable? A drug that your patient stops taking at week 3 has basically an effectiveness of 0. E is effectiveness. Compared to what? On what endpoints? Surrogate markers or patient-oriented outcomes? Mortality, hospitalizations, quality of life. This is where you apply everything you know about reading a trial. P stands for price. What does it cost the patient? What does insurance cover? And for which diagnoses? Is there a generic? A drug no one can afford doesn't make it into the conversation. And S is for simplicity. How complex is the regimen? What's the titration schedule like? Are there any monitoring requirements? What about storage considerations? Are there many steps when you go from prescription to adherence? And if so, the more steps there are, the more chances it can go wrong. All right, so let's look at this through the lens of comparing GLP-1 agonists to older agents. So for S and safety, again, we're thinking about the known risks and black box warnings. Things that we would think about here include GI effects, maybe thyroid C-cell tumor warnings, pancreatitis risk, muscle loss. Those things are all under investigation or are relatively high for our GLP-1s. T for tolerability. Again, who's going to stay on this? If we have really high GI intolerance, 30 to 40% of nausea through the GLP-1 medication, is that a concern compared to maybe a more well-tolerated phentermine? What about E for efficacy? When we look at the weight loss potential, there's a big difference. GLP-1s can produce about 20% of weight loss compared to about 5 to 7% in phentermine and 3% in orlistat. But what about some of the other things for efficacy to think about, like cardiovascular health? We know that GLP-1s can also help with that, so that might get you an extra check. For P or price, think about it. We have branded medications that require prior authorization and insurance companies to deem worthiness. That is what's preventing you potentially from implementing a GLP-1 regimen in a patient. Phentermine is generic. It costs about $20 a month and it's pretty easy to obtain. When we look at the last one, S for simplicity, thinking about injections, storage administration concerns, etc. Whereas phentermine or orlistat, they're just pills that you take about once a day. So let's look at the bottom line. GLP-1s are genuinely meaningfully more effective than anything else that has come before from an obesity pharmacotherapy standpoint. They've even been shown to lower cardiovascular risk for certain subgroups of patients, and that's real. But there's a big cost concern with them, and insurance coverage is not universally ubiquitous. That can be a problem and might lead you to think about giving phentermine to a patient who either has a high deductible or no insurance coverage at all. These trade-offs are worth a discussion, and they depend entirely on your patient and the priorities that that patient has. This is not criticism of any one drug class. It's steps working exactly the way it's supposed to. You putting some of the framework of these drugs into context so that you and the patient can decide the next best step. So let's hop into a real-world example. Your practice just got a pitch for a new electronic medical record system. The demo was stunning. The interface was clean, the rep was charming, and the slide deck had phrases like AI-powered workflow optimization and frictionless documentation. You are intrigued. Let's run the steps in this scenario. S for safety. Well, what happens to your patient data if the system goes down mid-visit? Are there any concerns with data breaches? What about tolerability? Will your staff, including the front desk coordinator who has used the same system since 2009, actually use this? Or will you spend the next 2 years drowning in workarounds and paper backups? Effectiveness. Does it improve patient outcomes or reduce errors or decrease documentation time? Or does it produce just more clicks per note and makes your inbox worse? Price. What's the implementation cost? Is there a monthly licensing fee? What does the productivity loss during transition actually cost you? What's the cost when the system goes down? And simplicity. How long does training take? Does it integrate with your existing lab systems and pharmacies? How many screens are there to document a blood pressure? The framework is identical. The stakes are similar. A bad EMR doesn't kill patients directly, but it absolutely affects the quality and effectiveness of care. And you'll be the one living with it for the next decade. Steps works for you whether you're talking about it with a patient or applying it to a more workflow example like we just did. So to sum up, STEPS stands for safety, tolerability, effectiveness, price, and simplicity. The next time something lands on your desk, a new drug, a new device, a new anything, you've got 5 questions that will tell you more than the rep slide deck ever will. New is not a category. Better is a category. STEPS helps you figure out which one you're actually looking at.